Hi guys, this is Alicia with Good Morning Sunshine. So today we had 4 lectures today, so I'm going to try to go through those as quickly as possible because I do have lab very soon. So I'm going to start today with pathology. So we learned about congestion, hemorrhage, and edema today, and our objectives are to understand the causes and mechanisms of edema, to understand the difference between hyperemia and congestion with its classification and implications, and lastly to understand the terminology and implications of different types of hemorrhages, which I don't even think he got to that part, but I'm going to try to explain them, or at least the notes I do have on that. So we started with a capillary wall. So it's semi-permeable barrier that influences the movement of fluids, nutrients, waste products between the blood and the interstitium. So the lipid soluble substances dissolve in the membrane lipid bilayer, but large proteins transport within the vesicles. Water and small polar molecules are through the inner endothelial pores. The movement is generally passive in response to concentration and pressure gradients. So water distribution between the plasma and the interstitium is determined mainly by osmotic, so that means keeping things in, and hydrostatic pressure, which means pushing things out. So those two differentials. I can show you a picture here. So we have the capillary hydrostatic pressure pushing out, as I said. It means pushing things out, and then we have the capillary osmotic pressure here trying to keep things in. So it's that balance that keeps everything together. However, the fluid that gets stuck outside goes to the lymphatics. So this is a lymphatic drainage. And then we have this picture that I'm going to explain to you real quick too. So all of these things are trying to keep the balance of fluid, like I said. So here, A, we have the hydrostatic pressure forcing fluid into the interstitium. So that's to the outside. As you can see the pores, it's going to the outside here, to the extracellular matrix. And then we have B here, which is plasma proteins leading to the osmotic effect, which means water attraction. So water is going into that cell right there. And then we have C here. So from there, exceeding fluid is drained into the lymphatic vessels, like I said. So whatever on the outside still in the extracellular matrix, so the interstitium, will go to the lymphatic. So, and that's where it's drained out. And then we have D, which is over here on this side over here. If you guys can see that over there. And then we have the interstitial hydrostatic pressure forces fluid into the lower pressure veins. So here's your veins right here. And then E, we have up here. This is the exchange of intercellular and interstitial fluid is balanced by the osmotic forces and concentration gradients of electrolytes and other molecules across the cell plasma membrane. So all these are at works. And then we should have an F here too, which I don't see right now. So, but anyways, and then so we went to the causes of edema. So we have one being the increased intravascular hydrostatic pressure. So active increase means hyperemia due to inflammation, and then we have passive increase as well, which is due to congestion. And then I'll be talking about the differences between these two in just a minute. So if a localized portion is affected, that's known as localized edema, and then heart failure is categorized as generalized edema. So then we have increased blood volume in the microvasculature. So I'm going to talk about the increased intravascular hydrostatic pressure now. So the portal hypertension, meaning the right-sided heart failure, hepatic fibrosis, can be caused by this. And then we have pulmonary hypertension, which is the left-sided heart failure, high-altitude disease. And then we have localized venous obstruction, which is due to gastric dilation or volvulus or intestinal volvulus and torsion, uterine torsion and prolapse, and venous thrombosis. But then also what can happen is fluid overload and then hyperemia, which means inflammation or physiological. So here we have a few pictures. So this dog has chronic heart failure, so the fluid in the abdominal cavities, that's known as ascites, and then we have increased hydrostatic pressure here, low osmotic pressure, and this is known as a subcutaneous edema here in this horse. But then we can also have decreased intravascular osmotic pressure. This commonly results from decreased concentration of plasma proteins, particularly albumin, increased fluid filtration, and decreased absorption. Hypoalbuminemia is caused either by decreased production of albumin by the liver or excessive loss from the plasma. So edema tends to be generalized. So again, decreased intravascular osmotic pressure can cause decreased albumin production, excess albumin loss, or parasitism, and renal disease, any of those things. So here, I've talked about before, we have hemorrhage contortus, which is a parasite that we learned in parasitology that I talked about, and that's on the left here, and then on the right, we have that bottle jaw. So then we got into sodium water retention. So salt retention occurs when renal function is compromised. So primary disorders of the kidneys and disorders with decreased renal perfusion. And then increased salt yields to obligate H2O retention, so obligate water retention, which yields increased hydrostatic pressure plus decreased vascular colloid osmotic pressure. Thirdly, we have increased microvascular permeability. So one, we have the initial microvascular reaction to inflammatory or immunologic stimuli. And then two, we have the localized release of mediators that cause vasodilation. Step three, we have the endothelial cell contraction, widening interendothelial gaps. And then four, we have subsequent release of IL-1 and TNF and interferon gamma. And then five, we have the cytoskeleton rearrangements yielding endothelial cell retention. So there's many like viruses, bacteria, all different kinds of infectious agents that come from the vascular leakage associated with inflammation. So viruses, this includes like influenza and other respiratory viruses. This includes canine adenovirus 1 and equine and porcine arteriovirus. But we can also have bacteria, like I said, we have Clostridium and things like that. And then we have Rickettsia. And then we have type 3 hypersensitivity as well. There's many infectious agents that go with this. And then for 4, we have decreased lymphatic drainage. So localize the area served by the affected lymphatic vessel. So with this, causes lymphatic obstruction or compression. So this is inflammatory or neoplastic masses such as fibrosis. And then we have congenital lymphatic aplasia or hypoplasia. And then we have intestinal lymphangiectasia and lymphangitis. So edema is basically based on location. So there's different types here. We have anasarca. So the affected tissue here is the generalized subcutaneous edema. And then we have hydroperitoneum, also known as ascites, which I talked about before. That's in our abdominal cavity. And then we have hydrothorax, which is in our thoracic cavity. We have hydropericardium, which is in our pericardial sac. And then we have hydrocele, which is in our scrotum. So an example of ascites is this picture on the left, and then we have anasarca on the right here. Then we also have a thing called Priskett disease, which is high altitude disease. This is the result of pulmonary arterial hypertension induced by pulmonary hypoxia occurring at high altitudes. So hypoxia-induced pulmonary arterial vasoconstriction and arterial hyperplasia reduce the diameter of the pulmonary arterioles, resulting in pulmonary hypertension and subsequent right ventricle hypertrophy. So now I'm going to talk about the difference, like I said, between hyperemia and congestion. So increased amounts of blood present in the blood vessels in a region of the body. So hyperemia, it may be caused by gradual arrival of blood to a tissue. This means increased blood flow. Whereas congestion is the blood accumulates in a tissue due to an obstacle preventing it preventing its exit. So that's decreased outflow. So here we have a normal arterial and normal capillaries and a normal venule. For hyperemia here, we have, again, increase in blood flow. So the beginning's bigger, as you can tell the differences here. And then for congestion, everything's fine until it gets shrunken here. So this is decreased outflow. So starting with hyperemia, so that's active congestion, also known as active congestion. It's increase in the amount of blood in any part of the arterial system. So it's an active process, and they are generally localized. So here's hyperemia, which breaks down into physiologic and pathological, and then physiological breaks down to increased demand, whereas pathological breaks down into inflammation, mechanical irritation, local radiation, chemical irritation, and hyperthermia. So hyperemia is active and mostly short duration process. It's physiological hyperemia is tissue with increased metabolic activity, stimulation of nerve centers that stimulate pressure, such as the medulla, the pons, the mesencephalon. This is like blushing. If you think of when you blush, your cheeks turn red, that's also hyperemia. But pathological hyperemia is an inflammatory process caused by vasodilator substances released from the affected tissues. Now getting into congestion is the increased amounts of blood in any part of the venous circulatory system due to impedance in its drainage. So this is a passive process. So blood's not leaving the tissue due to an impedance somewhere else. So congestion's also broken down here. So we have local congestion and generalized congestion. Local congestion is further broken down into acute local congestion and chronic local congestion. And generalized congestion is broken down into acute generalized congestion and chronic generalized congestion. So starting with acute local congestion, we have the compression of veins in a portion of the body. It is often the result of poor viscera position. Here's a few pictures on acute local congestion. And then we have those pictures as well. So the lipoma here gets around a portion of the intestine of the horse. But then we also have chronic local congestion, which is due to gradual or partial obstruction of venous circulation in an area, allowing the tissues to adapt to the lower blood supply. So due to an external pressure like neoplasia and large lymph nodes or abscesses, due to obstruction inside of a vein like thrombus, and then also decreased blood supply means decreased oxygen, but the tissues learn to adapt to this. The causes are cellular atrophy and proliferation of connective tissue, so fibrosis. And then we have generalized congestion. So we have acute, which is due to a sudden obstruction of blood flow in the heart or lungs. So etiology must manifest in a short period of time. But then we have cardiac causes of this. So those causes are degeneration and necrosis of the myocardium, the myocardial infarcts, or hydro or hemopericardium, supportive pericarditis. And then we have also pulmonary causes for this acute generalized congestion, which are pneumonia, embolism or thrombosis, hydrothorax, hemothorax, and empyema. But then we also have chronic generalized congestion, which is due to a chronic obstruction of blood flow in the heart or lungs, causing permanent alterations in various tissues and organs, such as atrophy and fibrosis. There's cardiac causes of this, which is valvular stenosis. We have valvular insufficiency. We have myocardial failure. We have cardiac anomalies and constrictive lesions of the epicardium and pericardium. And then our pulmonary causes for this, we have the obliteration of capillaries, so chronic alveolar emphysema, pneumonia, hydrothorax, hemothorax, empyema, and compression of major pulmonary vessels from tumor, cyst, and etc. And then we have generalized congestion of the right cardiac insufficiency. So this means the blood's accumulating in the liver due to right heart failure. So the blood accumulates in great veins and liver, the subcutaneous fluid accumulation in ventral areas, the extremities and body cavities, the liver with increased reticular pattern, chronic passive congestion or nutmeg liver, and then portal to center to vena cava, the accumulation of blood here. So this is our heart, or right heart failure, what it looks like. But then we can also have generalized congestion, so left cardiac insufficiency, which the blood accumulates in the lungs. So the extravascular erythrocytes in the alveoli and phagocytized by macrophages. So cardiac failure of cells, as you can see here, but this is left heart failure and what would happen. So there's increased pressure over the heart. There's pericarditis, and then hydropericardium, and tumors, abscesses, and granulomas. We have pulmonary disorders, which are grouped into two groups, so lesions in the pulmonary parenchyma and the vascular disorders, so altitude sickness. So we have pneumonia with 40% damaged parenchyma, which leads to a decrease in gas exchange due to alveolar exudate, which yields increased resistance to blood flow, which then goes to the dilation of the right ventricle and then to right heart failure here. So which leads to cor pulmonale, which is defined as an alteration in the structure and function of the right ventricle of the heart caused by a primary disorder of the respiratory system. So pulmonary hypertension is often the common link between lung dysfunction and the heart in this in cor pulmonale. So then we got into hypostatic congestion, which is the pulling of blood in the ventral areas of the body due to gravity. So that's what that looks like here. And again, he didn't get into hemorrhage. He's supposed to send us that last part of the lecture. I'm actually not going to go that with you because I'm just looking at it and I'm like, I don't know what I'm going to talk about. So that was the line of lecture 1. So then we got into virology. So we got into DNA viruses. Today we were talking about the parvovirus this time, and I think the pox virus. So starting with the parvoviruses, so some of those key concepts are they replicate in the nucleus of rapidly dividing cells, so they have to be active. The replicates encrypt epithelial cells, so in intestines responsible for epithelializing the rest of the intestine. Those are what the crypt epithelial cells are. Then we have the leukocytes. Those are those constantly turn over, and then we have the developing fetus. So it forms intranuclear inclusion bodies. It's stable in environment. It does not require direct contact with the infected animals to transmit. So it means biosecurity in this case is really important. You can't just separate the animals. Also resistant to heat, solvents, disinfectants, pH changes. She said we could use bleach. So again, biosecurity is key to eliminating transmission to healthy animals in parvovirus. So it ranges in size from 18 to 26 nanometers in diameter. They're linear, single-stranded DNA genome. They replicate only in the nuclei of rapidly dividing cells. DNA is converted to double-stranded DNA by host DNA polymerase. Canine parvovirus, mink enteritis virus, and raccoon parvovirus are host range mutants of feline panleukopenia virus. So that's where it all started, was with feline panleukopenia. So we're going to start there. It's endemic in unvaccinated cats. The disease occurs primarily in weaned kittens after maternal antibiotic wanes. Seasonal patterns related to the birth of kittens. It has transplacental infection, results in the fetal death or abortion, or cerebellar hypoplasia. The virus sheds through the feces, results in contaminated environments. The transmission is through inhalation or ingestion. The viral replication in the oropharynx and regional lymph nodes. Viremia develops in 24 hours, and the virus infects mitotoxically active cells. So those include the intestinal crypts, the bone marrow, the thymus, the lymph node, the spleen. And also the destruction of infected cells results in villus atrophy and panleukopenia. So clinical signs for feline panleukopenia are depression, vomiting, diarrhea, fetal death, and intention tremors, so cerebral ataxia. And death occurs secondary to dehydration and secondary infections. So here we have a regular cerebellum, And then we have a really shrunken one, and this is due to utero infection. And here we have red intestine due to hemorrhage and inflammation. And here's what it looks like. So we have crypt necrosis, we have thrombi, we have villus, blunting, and effusion here, and then we have intranuclear inclusions. So again, the virus mutated to raccoons and then mutated again to dogs, but this is all with cats. But however, a cat with parvovirus does not spread the disease to your dog. So next, we're going to talk about canine parvovirus. So emerged in the late 1970s. It has a high morbidity and mortality rate. Pups infected in utero died of myocarditis and heart failure until the adults developed immunity to this. Since then, most common disease seen is an acute enteric disease in dogs between weaning and the 6 months of age. Canine parvovirus continues to mutate and new variants emerge. So we have 2A, 2B, and 2C. Transmission is through ingestion, which is the same as the feline panco parvovirus. The viral replication in the oropharynx and the Peyer's patches. Viremia develops in 24 hours, and the virus affects, again, mitotically active cells. So that, again, includes the intestinal crypts, the bone marrow, the thymus, the lymph node, and the spleen. Destruction of infected cells results in villus atrophy, so that's more so in dogs, and immune suppression. Its clinical signs are depression, vomiting, bloody diarrhea, fetal death through myocardial necrosis. Death, again, occurs secondary to dehydration and endotoxemia. And then we have porcine parvovirus, so the pigs. This doesn't have to do with intestinal lesions, only with abortion, so that's what makes it different from the other parvoviruses. It's an important cause of reproductive failure worldwide. So sows are immune in endemic farms, but gilts may be susceptible to infection during mating and pregnancy. The virus targets mitotically active cells in the fetus. Transplacental infection occurs 10 to 14 days after infection. Damage to the fetus usually occurs between before 70 days of gestation and before the fetus develops immunity. The stage of the fetus determines the outcomes, so infection of embryos, reabsorption, and infertility. And then before day 70, we have a stillbirth or mummification, and after day 70, the pigs are born alive and healthy. So here's what that looks like. There's tiny little pigs in each of those cycles. So we have infection of embryos, and then we have before day 70, and then after day 70. So comparing and contrasting, all of these parvoviruses infect rapidly dividing cells, and they're extremely stable in environment. However, canine and feline are primarily enteric, maybe some fetal death, abortion. Cats are more likely to have panleukopenia, so white blood cells are wiped out, and in utero infection in cats can result in cerebellar hypoplasia. And then in porcine, it's primarily reproductive. So now we're going to go into pox viruses, so those key concepts. So unlike other DNA viruses, pox viruses replicate in the cytoplasm. Intracytoplasmic inclusions instead of intranuclear. Pox viruses are the largest viruses that cause disease in domestic animals. They're enveloped, they're double-stranded DNA viruses, they're stable in the environment under dry conditions. Their transmissions through aerosol, direct contact, and mechanical, such as insects. Infection usually resulted in raised skin lesions that progress to scabs. Viral proteins are released, including epidermal growth factor, resulting in epidermal proliferation. Endothelial infection results in vasculitis. And then we have generalized infections result in cell-associated viremia. So systemic infection results in lifelong immunity, and local infection develops transient immunity, and recurrence is possible in that case. So first we have capripox viruses, which is more systemic. It causes generalized infection and characteristic skin lesions. It eradicated from the U.S., so foreign animal, and it's a reportable disease here. We have sheeppox and goatpox, so we have lumpy skin disease in cattle. So here's what it looks like, and this is sheeppox right here. We have the proliferative dermatitis of the udder. And then here on this side, we have lumpy skin disease virus. So the proliferative bronchiolitis in the lungs here. So lumpy skin disease is capillary projections that go into the lumen, so there's no air spaces for gas exchange. Then we have avipox viruses. So we have fowl-pox, which affects chickens and turkeys. It causes lesions on the head and oral mucous membranes. It's transmitted by biting arthropods. And then separately we have pigeon pox and turkey pox. So here's what avipox looks like though. And then we have pseudopox virus, which causes mild skin disease. It's transmitted by the pig louse. And that's what this looks like here. And then we have the parapox virus. So all parapox viruses are transmissible to humans. So it affects young sheep, lesions around the muzzles and lips. So if we were to touch that, we would get it also. Same with bovine papular stomatitis. So this affects young calves, lesions on the muzzle, tongue, and esophagus. Again, if we touch, we'll probably get it. Pseudo cowpox. So the lesions are common on the teat. It causes milkers nodules in people. So now let's get into the pox viruses. So we have the rabbit myoxum virus, which is the cottontail rabbits are the natural host and develop only mild disease. European rabbits develop severe disease, however, with swelling of facial and periocular tissues. This virus was introduced to Europe, Australia, and Chile as a biological control measure. And then we have squirrel fibroma virus. It causes fibromas in squirrels. I can show you a picture of those. So comparing and contrasting, pox virus infection results in epithelial proliferation and vasculitis. Raised skin lesions that progress to scabs. Most diseases cutaneous by systemic infection can occur, especially with Capri pox viruses. Most pox viruses are host specific, except for parapox viruses. Capri pox viruses are considered foreign animal diseases, whereas parapox viruses are transmissible to humans. And then the poripox viruses infect fibroblasts, leading to fibroblast proliferation. So that was the end of that virology lecture. And now we have clinical pathology, so neutrophilia and neutropenia. So the main causes of neutrophilia are stress, so cortisol mediated. We have number 2 is excitement or physiological, so epinephrine mediated, and then third is inflammation. So starting with stress neutrophilia, so the cortisol comes from the cortex of the adrenal gland. Glucocorticoids are released under stress, this causing excessive levels of cortisol, and then excessive glucocorticoids. The storage pool is fully developed neutrophils. The circulatory pool, this is where we get our blood for our CBCs, and then we have a marginal pool, which cats have a bigger pool, but animals have this marginal pool as well. All these pools are where the neutrophils are being distributed. They're released from storage pool, then go to the circulatory pool. So I'm going to try to explain this to you. So here's the picture. But mature neutrophils are released from the storage pool. They have the ability to stick to the endothelial cell. Glucocorticoids downregulate the expression of these attachments for the neutrophils. The neutrophils get knocked off from the endothelial cells and go back to the circulating pool. This causes a mild neutrophilia. So mild neutrophilia is less than 2 times, so it's usually between 20,000. So mild neutrophilia is usually twofold, let's say that. So left shift equals bands. So those are the immature stages of neutrophils in the maturation pool. So bands are present, however, there is no left shift in this case here. There is a decrease in lymphs, so lymphopenia is important for stress. If you don't see this, it's probably something else. There's a mild hyperglycemia, so a mild increase in glucose, but there's no toxicity in this case. So CBC findings for stress neutrophilia is mild neutrophilia, no left shift, lymphopenia, like I said, monocytosis, plus or minus, and plus or minus eosinopenia. Chemistry findings, that may or may not be present in these cases are hyperglycemia, like I said, and increased ALP activity. So then we are going into excitement physiological neutrophilia. So this is part of the fight or flight response. So during this moment of excitement, the adrenal medulla release epinephrine. This increase in heart rate, this also increases cardiac output. These move out to the central circulating pool, so mature neutrophils move out here. And then moving marginal neutrophils out into the central pool due to the high flow rate of blood. This actually happens very fast, but is typically gone within 30 minutes. So epinephrine causes splenic contraction as well. This squeezes extra erythrocytes into circulation. The spleen has high levels of platelets, so thus more lymphocytes and platelets, these entering into the circulation as well. This results in a mild neutrophilia, so there's no left shift. There's an increase in lymphocytes, this making it different from the stress neutrophilia. Red cells will also go up, and there's a relative erythrocytosis. So total plasma proteins will not increase. However, the red blood cells will only increase. There's an increase in platelets, and glucose also goes up. So that's a mild hyperglycemia. And here's the picture to go with it. Everything I just talked about. And then CBC findings that support the interpretation of an excitement or physiological neutrophilia or mild neutrophilia, no left shift, mild lymphocytosis, erythrocytosis, so splenic contraction, and thrombocytosis, which also is splenic contraction. In chemistry findings that may or may not be present is that hypoglycemia. But then we also have inflammatory neutrophilia, so this is when if you see bands and toxicity on a CBC, then it's probably an inflammatory neutrophilia. Neutrophilia is usually greater than the twofold, like I said. Maturation and storage pools are now in place, so bands are in play now. So here's our picture. So there's an inflammation happens, which releases inflammatory cytokines, which sends out cells to maturation and storage pools. These cells are released in order, so seniors have priority. The mature released first to the bone marrow as the need increases, so cells keep sending signals that they need more help. This is when the band cells are sent out, so they help with innate immune response. These now appear in the circulation. We will now see a left shift on the CBC. There are also recruiting neutrophils from the marginal pool to the inflammation site. As this process goes on, the inflammatory cytokines have a trophic effect on the bone marrow. The bone undergoes hyperplasia. This increases neutrophils in maturation and storage pool. This increases the number of cells in circulation, thus inflammatory neutrophilia. Bands start to diminish by the amount of neutrophils stay increased due to this. These may or may not be present. That's the globulins increase. The decrease of albumin and glucose is variable. So the CBC findings for this one is neutrophil count is greater than twofold. There's a concurrent left shift. There's neutrophil toxic change. There's neutrophilia twofold. And then concurrent lymphocytosis suggests chronic inflammation. So we can rule out the causes of lymphocytosis. And then we have monocytosis and hyperphrenogenemia, which is the decrease in fibrogen. So we have acute and chronic inflammatory neutrophilia. So the acute is tapping into the storage and maturation pool with our bands. Chronic is the expansion of hyperplasia, so the increased number of neutrophils in circulation. And then we have a leukemoid response, which has to do with leukocytosis with increase in white blood cells, so in neutrophils. It is a subtype of chronic inflammation. It's called leukemoid. Given numbers of the white blood cells are increased similar to leukemia. Its causes are immune-mediated hemolytic anemia with the resulting tissue necrosis, death from severe anemia-induced hypoxemia, and or thromboembolic disease. So the P's, basically you're looking for anywhere that has pus in order for it to be called this response. But inflammation can also happen without neutrophilia. So normal neutrophil numbers plus a left shift, or normal neutrophil numbers plus a neutrophil toxic change. So now getting into neutropenia. So we have the main causes of neutropenia, which is inflammation, decreased production, and sequestration. Starting with the inflammatory neutropenia, its pathogenesis is utilization is greater than production. Conditions are severe infections such as sepsis and acute inflammation for ruminants. We have hematologic support, which is a left shift, and toxic neutrophils. So again, this occurs, inflammatory neutropenia occurs when the bone marrow cannot keep up, so there's decreased neutrophil numbers and associated with left shift and toxicity. So again, CBC findings for inflammatory neutropenia is other lineages, so red blood cells and platelets unaffected if decrease caused by other mechanisms. We have a plus or minus a left shift, a plus or minus neutrophil toxic change, and plus or minus lymphopenia. Its chemistry findings that may or may not be present are hypoglycemia due to sepsis. And then we have decreased production neutropenia. So this is cytopenias decreasing from the bone marrow. There's no left shift or toxicity. We have decreased platelets, decreased red blood cells. So this meaning something is wrong with the bone marrow. So we have myelosuppressive agents and toxins such as viruses. We have FELV. We have the parvovirus for bacteria. We have Ehrlichia for drugs. We have chemotherapy. For toxins, we have plants, and idiopathic, we have autoantibodies. For myelofibrosis, we have myelitis, leukemia, and myelofibrosis. So we have CBC findings that support neutropenia due to decreased production. So we have plus or minus decreases in other lineages, so red blood cell count, non-regenerative anemia, and thrombocytopenia. We have plus or minus the presence of many immature blast cells supporting acute leukemia. And then we have plus or minus identifiable infectious agents. So why is there neutropenia? Well, neutropenia results from myeloid granulocytic hypoplasia, so decreased neutrophil production in the bone marrow. Viruses with tropism for rapidly dividing cells, so the lymphoid system, bone marrow, and GI tract. So parvovirus, canine parvovirus, and feline panleukopenia, canine distemper virus, infectious canine hepatitis, and bovine viral diarrhea virus. And then we have Ricocell agents, which is chronic Ehrlichia canis infection. And then we have toxins, we have drugs, we have estrogen, all these things. That is why there's neutropenia. And then we have the sequestration of neutropenia, which is exposed to an endotoxin, so a decline in neutrophils that way. This is a rapid, really fast. So that was the end of clinical pathology. And then we ended it with parasitology 9, which we now are talking about protozoa. So protozoa parasites are unicellular. They're eukaryotic organisms. That's making them different from bacteria. Several different groups have members that are parasites of animals and humans. So ways in which protozoan groups differ is through their locomotion, which is a species may use cilia or flagella or have no specific organelles for movement. Reproduction may be sexual, asexual, or both. Location of the host, some extracellular, some are intracellular. In life cycles, they can be direct or indirect. So the way protozoans differ from worms, protozoans are single-celled. They're often host-specific. They're asexual and may be sexual reproduction in vertebrate hosts. Numbers in vertebrate hosts may increase by reinfection or multiplication, known for microparasites. Individual can transform into new stage in final host and go on to infect a new host. Diagnostic stages seen in fecal samples are called oocyst or cyst. So whereas in worms are multicellular, they're often host-specific, which that was the same in protozoa. However, sexual reproduction only in the vertebrate host. Numbers in vertebrate hosts are increased by reinfection. For macroparasites, adult worms cannot transform into a different stage, and diagnostic stages in fecal samples here are eggs or larvae. So again, protozoans are unicellular eukaryotic organisms. There's several different groups that have members that are parasites of animals and humans. We have Acomplexa, this is a phylum. We have flagellates, cyllates, and amoebae. Phylum Apicomplexia is the most important and complex of the protozoan parasitic groups. It can be divided for our purposes into Coccidia type organisms, so that's based in the GI tract. And then we have Sporozoa, which are blood parasites, so hemoparasites. But starting with the coccidian parasites have at least one stage in the GI tract, so they're highly successful and widespread group. They have sexual and asexual reproduction. Sexual reproduction is always in the definitive host, whereas asexual reproduction is in the intermediate host. Most are parasites of the GI tract, both direct and indirect life cycles depending on the species. Usually host specific for hosts where sexual reproduction occurs. Clinical disease is primarily related to the GI tract, so diarrhea is the most common sign, usually diagnosed by identification of stage specialized for transmission in feces, so that's known as the oocyst. Coccidiosis is the general term of the disease coccidia. GI diseases caused by coccidia parasites, again, is called coccidiosis. Coccidiosis. There we go. Usually a disease of young animals in combination with environmental factors, so heavy exposure to oocysts, stress, diet change, weaning, and other. Immunity limits further infection and prevents disease. Coccidiosis are passed in the feces. It has a thin shell with single cell inside, smaller than a strongylo egg. It's highly resistant to environmental conditions, may survive more than 1 year in protected locations out of direct sun or desiccation. Survive very well in animal housing and outside. They undergo sporogony in the environment, so becoming a sporulated oocyst. A sporulated oocyst is the infective stage. A single cell undergoes division in the environment to form sporocysts containing sporozoites. So sporozoites is usually double of the sporocysts. So if you have 2 sporocysts, you would then have 4 sporozoites, if that makes sense. So starting with the simplest life cycle in the group, we're going to start with Emeria. It's a common intestinal parasite. It's in ruminants, birds, rodents, pigs, and others. It's very host specific, so won't infect other species. Economically important parasites of ruminants and poultry. The host may have more than 1 species of coccidia. So here's their life cycle here. I'm going to show you and I'm going to go over it with you. So sporogony occurs in the environment. Oocysts are going to sporulate from one cell to 4 sporocysts with 2 sporocytes inside, so that's 8 in total. Like I said, it doubles. They have to be ingested by the host. Once they're ingested by the host, they go to the small intestine. Excitation happens and oocysts release sporocysts. The sporocysts release sporozoites. These invade the gut cells. They get into the cell, forming a trophozoite. This then turns into a schizont, going through schizogony or merigony. Then there are merozoites released from the schizoid. This is now going to the large intestine. These can go through a reinfective cycle, so becoming 2nd or even 3rd generation. The merozoites will then differentiate into male and female gametes, so this is known as gametony. These develop the developmental oocyst, which is then shed in the feces at day 7. So this disease is caused by the destruction of cells as coccidia stages emerge to continue their life cycle. Pathogenicity of each coccidia species are affected by cell type infected. So for example, infection of epithelial cells at the tips of villi results in less damage than the infection of regenerative cells at the base of the villi. So each species uses specific cells. And then we also have a ruminant coccidiosis life cycle. It's basically the same cycle that I just went over. So ruminant coccidiosis, ruminants infected with multiple host-specific Emeria species worldwide. Not all species are pathogenic. In cattle, more than 20 species. However, Emeria bovis and Emeria zerni are the most pathogenic ones. Sheep and goats also have just a few species that are host-specific that cause most diseases. Immunity is species-specific and partial. So what kind of immune response is it? It's T helper 1 immunity because it's an intracellular organism. All animals routinely exposed for an early age. Early on, some protection from dam and immunity gradually develops. Adult animals carry low level of infection. So going on with ruminant coccidiosis, pathology and clinical outcome influences by several factors, including Amira species present, the infection dose, species replication potential, inflammatory immune response, concurrent infections, management practices, and related stress. So the impact of this infection, so subclinically, some studies show impacts of weight gain, however, better for the animals to have this disease for immunity reasons for the entire herd. And then clinical disease is mild to severe. So diarrhea with blood is if very severe. We have fecal stain perineal area. We have straining to defecate and subsequent rectal prolapse, weight loss and or stunting, and death. The diagnosis is all young animals have oocysts and they're newer by a few months of age. The presence of oocysts alone doesn't provide diagnosis of coccidiosis. Clinical judgment is important here. For the control of this, we fix environmental elements that disrupt balance, improve sanitation, so feel off the ground, fix damp spots, which are good for oocysts, reduce stress, and use of coccidial drugs. But then there's poultry coccidiosis, which is specific to chicken. Each type of bird host infected with multiple different Amira species. One of the most important production diseases of confined poultry is several billions of dollars spent worldwide annually for prevention in broilers. Also can be a problem in backyard chicken flocks. Coccidia species vary in pathogenicity. Different sites of infection, which include the cecum, the large intestines, or small intestines, which can produce different signs. In confinement housing, all birds receive some form of prevention for coccidia to reduce severity of infection. We have anti-coccidial drugs, vaccine composed of live oocysts. Backyard birds may have food containing drugs for prevention and be treated with the disease helps. Other domestic and wild birds have their own species that can be pathogenic. And then we stop there. So that was the lectures for today. Lots of information. My voice now hurts. But yeah, I'll be heading into lab in just a few. But I hope you guys all had a good Monday. I'm gonna be tired again, but it's okay. Almost there. But yeah. I love you guys, and I hope you guys all had a good day.